78-year-old female presenting complaint, tiredness of 3 days duration, vomiting 2 days duration, cough and breathing difficulty of 1 day duration.
So what are the possibilities here?
Sir, cough and breathing difficulty of 1 day, vomiting 2 days, tiredness.
This can be anything. This can be anything. Tiredness, systemic.
Tiredness, system, not specific.
Okay. So somebody is vomiting for 2 days.
2 days.
Then developing difficulty. What
difficulty? It can be aspiration. One thing.
Yes. Which are the bronchopulmonary segments where commonly aspiration takes place?
Aspiration takes place in the apical segment of the lower lobe, in the right side.
Okay.
Then posterior segment of the upper lobe.
Which are the common organisms?
In aspiration pneumonia, mainly chemical pneumonitis.
Any other organism you suspect?
Anaerobic.
Okay. So which are the scenarios where people get aspiration pneumonia?
In alcohol patients.
Yes.
Then any patient with a stroke or CVA, they are unconscious.
Very good.
Seizures, following seizures.
Head injuries.
Anesthesias. Post anesthesia. Any oral procedures, dental procedures. Or procedures.
That's right. Okay, let's go forward. History of the present illness of this patient is?
History of presenting illness. Patient is complaining of tiredness of 3 days duration, which is insidious in onset and progressive, which limits her routine activities now. And vomitus contains food particles, which is not blood stained. Cough while taking of the food, followed by breathing difficulty.
So you already mentioned that is possibly a
aspiration.
Okay. For past history?
Past history, there is a history of radiation therapy given 40 years before for swelling near the left side of the neck. Then history of hypothyroidism on regular medication and history of coronary artery disease.
What can you make out now?
Yes, sir. It can be the hypothyroidism on regular medication. Radiation therapy may be causing.
Yes. So how do you differentiate radiation-induced hypothyroidism from autoimmune hypothyroidism?
Clinically, sir?
Yes. When there is a hypothyroidism due to radiation, the excess amount of TSH produced cannot produce a large
thyroid. Sir, the autoimmune thyroid disorders will be associated with goiter. The radiation hypothyroidism.
Provided it is primarily a disease of the
primary
hypothyroid
disease,
gland.
Thyroid gland, AATD, primarily anti-T2 positive. Then those glycosaminoglycan glycosation deposition manifestations all will be there with the primary AATD only.
That's good.
Those like myxedemas and those manifestations.
And when we examine this patient, this is the picture.
Okay, sir. Okay. So the drooping of the shoulder.
What can you make out?
Drooping of the shoulder. Left side present. With
look at the back scapula. Of the patient.
There is a gibbous deformity.
Any discoloration of the skin?
Yes. Ulceration with erythematous.
That is only a post-inflammatory hypopigmentation. That white things in the midline. Okay. She's
conscious, pallor present, pulse 78, regular in rhythm, low volume, left brachial radial pulses are feeble compared to right, and left. Okay. Then BP is 100/60 millimeter of mercury in the right upper arm.
So this low BP can be due to what all factors? She's coming with vomiting.
Low BPs can be due to vomiting, hypovolemia.
Okay. How do you explain the left brachial plexus?
Hypothyroidism also can produce low cardiac output status. Patient is already hypothyroidism.
But not usually hypothyroidism unless there is a severe pericardial effusion.
Oh, okay, sir.
Association with the hypertension.
Sir?
So what do you think about the pulse?
Pulse regular rhythm 78. Left brachial and radial pulses are feeble compared to right, means fibrosis.
Can you make out anything about the pulse?
Stenosis of the left subclavian stenosis.
Left brachial and radial pulses are feeble on
Feeble compared to right
side compared to
left, right side. So left.
What are the causes of this asymmetry?
Stenosis, subclavian stenosis, left side.
That's good. Good. Yes.
Then
what are the physiologies you postulate?
one is that radiation.
Okay, radiation.
Yes. One thing. Then any recurrence of any neck malignancy, what happened that didn't mentioned in the history. So any recurrence of whatever malignancy occurred.
That's right. You have to, in young person, you think about Takayasu disease.
Takayasu, young patient, this age group is 20-year-old.
Against, yes.
Takayasu is usually young adolescent females.
That's good.
Okay,
good.
Okay, sir. Okay.
Any syndrome in relation to the neck? Outlet syndrome? Thoracic outlet syndrome.
Thoracic outlet syndromes.
Which includes cervical rib?
Cervical
section, anything that infiltrates over there.
Yes.
Can any cardiovascular disease produce this picture?
Coagulation of aorta.
Where is the usual site of coagulation of aorta?
It can be pre-subclavian or post-subclavian.
Then you have to put adjective there. Pre-subclavian.
Pre-subclavian
coarctation.
Coagulation of aorta.
Coarctation itself is the wrong answer, but pre-subclavian is okay.
Okay.
Yes. So, anything else can you make out in cardiovascular system which can produce reduced pulse? Can there be an embolism?
Yes, sir. Yes.
Yes,
sir. Thrombus
there can be an embolism.
There can be an embolism.
Is there a chance of being a post-Blalock shunt surgery? You can have estimate of the pulse.
Okay, sir.
And if somebody has done a procedure like angiogram through the brachial artery, again the pulse may be feeble.
Thrombus. Okay, sir.
And if anybody has taken a radial artery for grafting, again you may be finding it difficult. So, how do you localize anatomically which vessel is in trouble? Radial is in trouble, brachial is in trouble. So, what next?
Axillary pulsations.
And before that, proximal to axillary is? Axillary is continuation of which artery? Subclavian. So, how will you recognize subclavian stenosis?
Subclavian, clinically, subclavian bruit may be there.
Where do you look for subclavian bruit?
Just below the clavicle, auscultation.
Just below or just above the clavicle? And what symptoms usually they have?
Subclavian steel syndrome.
What are the symptoms of subclavian steel?
Patient will have, when using the same hand, the patient will have posterior vertebrobasilar insufficiency symptoms like ataxia, giddiness.
Good.
That's symptoms.
So let's go to the respiratory system.
Sir, respiratory system, upper respiratory tract, poor oral hygiene, no dentures. Lower respiratory tract, drooping of the left shoulder present. Skin over the upper part of the chest is hyperpigmented and indurated and scarred. Trachea shifted to the left. Bilateral supraclavicular hollowing and flattening of the left infraclavicular area present and left supraclavicular area present. So,
what do you make out of this?
This drooping of shoulder with evidence of upper lobe volume loss.
Yes.
Could be post-radiational fibrosis involving the left upper lobe.
It need not be post-radiation. It can be any fibrosis.
Any fibrosis, okay, sir.
You need not commit about radiation. It can be TB, it can be anything else.
Okay, sir. Fibrosis involving the left upper lobe.
Why don't you think collapse is the cause?
Collapse is also a possibility, sir, but in the background of
usually collapse patients are very, very symptomatic.
And acute causes only mainly. This
That's
is
right.
more of a history. History is acute.
And if you demonstrate there is structural defect, that means it's chronic process.
Chronic process. Structural defect is.
So, that's a structural problem here. So, 2 points are there: onset, duration, and symptoms. All the three are not favoring us.
Not really.
Then the respiratory system continues.
Respiratory system, movements of the chest wall is reduced over the left side, decreased vocal fremitus and decreased vocal resonance, and with dull note on percussion, decreased breath sounds and crepitations present over the supraclavicular, infraclavicular and supraclavicular areas.
So what do you make out now?
Suprascapular areas. Okay, sir, decreased vocal fremitus and resonance is can be there in fibrosis and collapse. Then dull note, fibrosis again, decreased breath sounds again fibrosis, crepitations also favorable for fibrosis.
So points against it in being a decreased crepitations against collapse. Structural changes are against collapse. And vocal fremitus can be increased in fibrosis, can be normal in fibrosis, can be diminished. But in collapse, probably expect it to be lower. So, so your conclusion about respiratory finding is?
Respiratory finding is suggestive of left upper lobe fibrosis.
Why do you say upper lobe?
Upper lobe means mediastinum we still didn't come, but mostly upper zone is producing shifting of trachea and drooping of the shoulder with the supraclavicular hollowing and infraclavicular flattening as such. So it's
right.
More
so if you
we don't know accompanied lower lobe is there or not, but upper lobe is definitely there.
Let us go to the basic. Where is the oblique fissure or major fissure? How do you draw on a patient?
Sir, oblique fissure, it starts from the 2 centimeter lateral to the T2 spine, and it cuts in the.
You position
ends in the 6th rib in the mid clavicular line, and it crosses 8th rib in the anterior axillary line and 10th rib in the mid axillary line.
Then you just position the patient such a way that the right hand is on the left shoulder or left hand on the right shoulder, and draw the point from the T2 spine along the medial margin of the scapula, and as you said, it comes and touches the 6th rib over there. Okay.
6th rib.
So these findings given to you are all above that line.
Above that line. Okay.
Okay, right.
Okay.
CVS examination findings.
Yeah, cardiovascular system apex beat is in the left 6th intercostal space, 1 centimeter lateral to the mid clavicular line.
What do you think it is?
So there is a mediastinal shift also is there.
Or it can be cardiac disease? Or it can be cardiac disease?
It can be cardiac disease.
Okay, right. Then.
Okay, sir. Then there is an ejection systolic murmur of grade 3 intensity heard in the left 2nd intercostal space, 3 centimeter lateral to the sternal border, radiating to both carotids.
Yes. So what can it be?
It can be aortic. In this age group, it is sclerotic AV valve.
So where is the murmur of the sclerotic AV valve heard?
In the aortic area.
Where is it?
Sorry, sir. This left. Sorry, sir. Left. Sorry, sir. I read it as right. Okay. Mine. Okay, sir.
So where is the aortic area?
Aortic area is in the right 2nd intercostal space.
Okay. Okay. So what do you think is the murmur due to?
This murmur is due to, but considering the fact that there is a stenosis radiating to both carotids, so it is aortic only.
Okay, don't worry.
Okay,
so there is loss of volume of
volume is there, so it can be because of the shift. Maybe hearing, sir. Okay. Loss of volume loss in the lung made a shift of the cardiac, so that this aortic murmur, same AS murmur, may be hearing in that side because of the cardiac shift, structural shift.
We'll go ahead.
Okay, sir. So
carry on.
Okay, sir. So loss of volume left side of the chest, differential diagnosis, left lung fibrosis and left lung collapse.
Okay. So, then tracheal shift to
left side and apical shift to left side.
Possibilities are
tracheal shift left upper lobe fibrosis and left upper lobe collapse. Apical shift is also left-sided fibrosis and collapse, or the right-sided pleural effusion with a pneumothorax.
Okay, so you have got some differential diagnosis here, no?
Yes, sir.
Okay. So what you already said, ejection systolic murmur is because of the aortic stenosis. Other causes of ejection systolic murmur in the left intercostal space.
Pulmonary stenosis.
Okay.
Then in this left HOCM.
Okay,
That's
fine.
it.
Okay, what are the conditions?
Okay,
Physiologically, you can have some
functional murmurs. Okay, sir. Okay, sir.
Thyrotoxicosis, whatever it is, anemia, pregnancy. Organic diseases, pulmonary stenosis, one you already mentioned, yes. Then pulmonary
artery hypertension. Okay.
hypertension can be there. What about ASD?
ASD there can be, because of the increased flow, there can be murmur in the pulmonary.
That's right.
That's it.
So it's something like a functional murmur only.
Functional murmur.
There's a murmur.
Murmur.
Hypertrophic cardiomyopathy you already mentioned. Yes. Tetralogy of Fallot.
Is a part of pulmonary stenosis in that component.
Yes. What about VSD?
VSD, membranous VSD.
Membranous
Or increased
VSD
flow, or increased flow from the left to right, that can produce flow through the.
Or there can be associated pulmonary stenosis. No?
Okay.
That's also possible.
Okay, sir.
So, what's the basic principle regarding conduction of murmur?
Conduction of murmur means the blood flowing to that direction, where blood is flowing
That's
from
right.
to that
That's
direction.
right. Absolutely correct. So, why do you say aortic area, the name aortic area? Why is it so? Why the name aortic area?
Because the aortic valve sounds, everything is radiating to that side, conducting to that side.
Commonly
Which is
the
better
valve
heard in
is
that
situated-
area.
That's right. Commonly the valve is situated in that area. Sound from that valve is best heard in that area.
Best
That's
heard
why
in
it's
that
called aortic area.
aortic area.
Suppose the aortic area is shifted, heart is shifted. Where is the aortic area then?
Aortic area will also.
It will be in the new area.
New
area where
it will be shifted.
Why do you call pulmonary area? Because pulmonary sounds are better heard there.
Yes, sir.
So it can also shift.
Shift.
So
Yes, sir.
areas are not applicable if the heart
When
is
that is shifted.
from position.
Okay.
So that's why you have the confusion here regarding. So what are the common causes of upper lobe fibrosis and lower lobe fibrosis?
Sir, upper lobe fibrosis most commonest causes tuberculosis.
Tuberculosis, very good. Is it a unilateral disease or bilateral disease?
Which one, sir? Tuberculosis. Tuberculosis is childhood bilateral disease.
Commonly, but clinically you may get only
Clinically,
one
you
side.
get only one side.
So the flattening of the opposite side mentioned the early part may be
Okay,
still
sir.
be applicable. When you take X-ray, you may find some changes,
Okay, sir.
and it can be rarely unilateral also. That's also possible. Yes, other causes of upper lobe fibrosis.
Bronchiectasis, upper lobe secondary to upper lobe bronchiectasis, that can be fibrosis.
Which condition?
Cystic fibrosis.
Causes of upper lobe bronchiectasis. One is
One is cystic fibrosis, another one is traction bronchiectasis secondary to tuberculosis.
cystic fibrosis is usually not confined to upper lobe alone.
Upper lobe alone, it's a diffuse.
Probe.
Traction
And
bronchiectasis, sir.
That's right. And you have got selectively some upper lobe diseases producing bronchiectasis. One is ankylosing spondylitis.
Okay, sir.
Another one is the disease called allergic bronchopulmonary aspergillosis,
Okay, sir.
predominantly producing the proximal airway bronchiectasis.
Okay, sir.
Next possibility will be radiation.
Radiation.
So bronchiectasis of the upper lobe, how do they present?
Hemoptysis.
What's that called?
Bronchiectasis sicca.
Sicca. So okay. So one cause you said traction, bronchiectasis. Second you said as tuberculosis. Other causes. any
occupational disorders like asbestosis, silicosis.
No. Asbestosis classically in the lower lobe,
Okay, sir.
and asbestosis is only one occupational disease affecting the lower lobe. All other occupational lung disease like coal workers, pneumoconiosis, and silicosis comes in the upper lobe.
Oh, okay, sir. Okay, sir.
So we have got tuberculosis as a possibility. We have silicosis, we got asbestosis, allergic bronchopulmonary aspergillosis, extrinsic allergic alveolitis, allergic bronchopulmonary aspergillosis, radiation fibrosis. Okay, beryllium is another one.
Oh,
Beryllium.
Okay,
So never forget beryllium. Langerhans histiocytosis is another one.
okay, sir.
Okay, so that can also produce.
Okay, sir.
Some people say psoriasis, but I don't know whether psoriasis will produce. I have not seen one. Some people say psoriasis can also produce, but I am not sure.
Okay, sir.
What about lower lobe fibrosis?
Lower lobe. Again, tuberculosis.
Tuberculosis can be anywhere, but commonly it is
Anywhere.
upper lobe.
Upper
Lower
lobe.
lobe tuberculosis
Then,
occur in diabetic patients, HIV patients, immunocompromised patients, predominantly lower lobe. Okay,
Okay, sir. Drug induced.
excellent. Which are the drugs producing fibrosis?
Methotrexate.
Excellent, good. So
Amiodarone.
lower lobe dominant, amiodarone, very good. Okay.
Amiodarone.
What other than drugs? What else?
This all viral infection. This viral interstitial pneumonia,
Interstitial pneumonias. Okay.
interstitial fibrosis. It produces that.
Due to what? Broad group called connective tissue diseases.
Connective tissue disorders. Rheumatoid arthritis. Scleroderma.
Sclerosis.
Scleroderma.
System sclerosis. Okay. So this is dominantly and asbestosis. Excellent. So that also comes in the lower lobe.
Lower lobe. Okay.
So we have. So what is your final diagnosis in this case?
Final diagnosis is left upper lobe fibrosis with no features of respiratory failure, no features of core pulmonary, with a probable sclerotic aortic stenosis.
How do
Probably
you
etiology
differentiate
fibrosis.
sclerotic aortic stenosis from aortic stenosis? Aortic sclerosis versus aortic stenosis. What are the points to differentiate?
One is aortic sclerosis. The Gallavadian phenomenon will be present. That
Need not be.
need not be. Okay. Then the conduction in the murmur is
Not usually heard in aortic sclerosis.
aortic
Good.
sclerosis.
The A2.
A2 will be loud in this calcified valve.
Aortic sclerosis. Aortic sclerosis.
Sclerosis.
Not in stenosis.
Not stenosis.
And thrill is usually characteristic of
Stenosis.
stenosis, not sclerosis.
Not
So
sclerosis.
there are a couple of points. And if you look at the pulse, it's a low volume pulse in case of aortic stenosis, high volume pulse in case of aortic sclerosis.
Okay, sir.
Aortic sclerosis. So you have the diagnosis here. So how does radiation produce problems?
Okay.
Radiation can produce problem in the heart, acute stage by cardiac injury, pericarditis and myocarditis.
Okay, sir.
But as the radiation is over, you find that they have got effect of this acute effect, like late cardiac injury producing constriction, fibrosis of the pericardium, constrictive pericarditis. They go for static cardiomyopathy. And if the coronary is also irradiated, they may go for coronary disease. So this patient is having coronary disease. It can be related to her age, atherosclerosis. Alternatively, it can be radiation-induced sequelae of long term. And it's also known to produce valvular problems, as you correctly pointed out. So it is possible that this patient's aortic involvement may be because of the post-radiation effect.
Okay, sir.
Another effect is conduction defect, which is not seen in patient. The radiation affects the skin, as you have seen, and it can affect any part of the body, any structure over there, maybe mediastinum, big vessels, medium and large vessels. So collectively you can call them as vasculopathy,
Okay, sir.
affecting thoracic aorta, carotids, axillary, subclavian artery stenosis. So, this is the effect of radiation possibly in this patient. There is vascular involvement, valve involvement, coronary heart disease, and post-radiation hypothyroidism and fibrosis. So, what are the hazards, risk factors for cardiovascular injury?
Sir, general.
The high radiation dose. 40 years back, the radiation was in the primitive state, not like now. Now we have linear accelerators. It was a very blind radiation. Whole area is irradiated and burned out. And the amount of protection used to be minimal. Now there's a lot of protection now. And if you are doing blind radiation, whole heart is affected. When you do the current technique of linear accelerator, you focus the area and irradiate only that area. And if you gave radiation at a young age, possibly she was in her late 30 when she had this radiation, 40 years later, so young age at radiation and she's living long, can be having gradual fibrosis. Okay, so the interval between the time of radiation and her life expectancy also decides. And just like any other human being, she may have some risk factor for cardiovascular disease. So this patient tells you briefly it's a post-radiation problem producing the respiratory system is producing fibrosis of the upper lobe. We discussed the causes of upper lobe fibrosis. And second part is cardiac injury, valve, vessels and coronary possibly. The third part of the story is she has hypothyroidism, also possibly having post-radiation injury. So, the final diagnosis is very simple, affecting all the systems, can be easily explained. This case is a rare specimen in the sense, this type of cases are rarely seen nowadays. Only if they live long enough to come with these findings, we'll be able to see. That's what we're discussing today. The fibrosis we do see, but this type of extensive fibrosis producing this type of deformities plus cardiovascular system involvement makes it interesting, and that's why we are discussing the case today. We didn't think it's a possibility of atherosclerosis in this case because commonly it is lower limb vessels that is commonly affected in atherosclerosis. Lower limb vessels being normal and only upper limb vessels are affected. We thought possibly this is the effect of radiation, also because the heart is shifted, showing thereby the whole area is affected by radiation. Any questions or doubts about this case? No.
No, sir.